we've got to start thinking differently. We've got to deconstruct psychiatric diagnoses. There is a phenomenal paper that's come out that has shown that overall in the DSM, there are 628 symptoms, right? Across the board, 628 symptoms, out of which 231 of those symptoms, they are found across the entire chapters. They basically repeat across several diagnoses, a total of 1,022 times. What that tells us is that diagnoses or diagnostic categories we know clearly don't have clear boundaries. And this is why the overlap is there, the debates with diagnosis, etc. And interestingly, the top symptom across that entire group, the one which overlaps the most, is insomnia. And we will see why understanding the phases of sleep, understanding how ADHD links to sleep is really important. So I will be sharing patient cases. There are some verbatim statements, some actual images. These I've obtained informed consent for them. Remember that ultimately each patient's unique and that individualized risk-benefit analysis should be carried out. So please do seek advice with any changes should that be needed. But I will be giving you the foundations and the principles for those aspects. So this is maybe a slightly provocative sort of statement, but it's based on what William Osler said. And he said, of course, we know with regards to medicine, the dichotomy, there isn't really a mind-body dichotomy. ADHD is very similar. There are no true experts in ADHD, since to be an expert in ADHD is to recognize its manifestations across the lifespan, because it is a neurodevelopmental picture, and its relationship to other psychiatric disorders, because the comorbidity rates range from anywhere to 50% to 80%. So it's a huge comorbidity. Thus, an ADHD expert is an expert across psychiatry as a whole. And that's the foundation with which we look further. When we think about ADHD, we've got to get back to evolution, because the big question that people often, or the debate that happens, is does this patient have ADHD or does this patient not have ADHD? The way to think about it is that we're all on a spectrum where there are certain genetic vulnerabilities, then there are epigenetic changes from the environment or trauma or substances, other factors, diet and sleep, etc. So you've got genes, the vulnerability factors, then you've got the environmental and multi-pronged aspects coming in, and then that leads to what's known as that reward sensitivity dimension, or a reward deficiency dimension. Some people have none, whilst others might have really significant reward deficits. And we'll come to that specific concept. So the impact of evolution on the genetic makeup of Homo sapiens in terms of survival must be considered. Genes related to the dopaminergic system, liability, may have served an important survival tactic, but in our current society may no longer serve survival. Carriers of DNA polymorphisms, and specifically the DRD2 TAC-A1 allele, with behaviors such as competitiveness and selfishness may have had survival advantages as hunter-gatherers millions of years ago, but in today's world may be counter to achieving positive relationships and happiness. This conundrum may advance the unfortunate condition that Homo sapiens are wired to seek pleasure in all its forms, no matter the cost to oneself, others, and one's surroundings. Now, what's important here is that when dopamine evolved 600 million years ago in unicellular organisms, it was one pathway, which was the excitatory pathway. For food seeking, survival, reproduction, that was the unicellular excitatory pathway. But as evolution progressed, and particularly in mammalian forms, primates, we developed the inhibitory pathway. So we'll see this, the excitatory pathway and the inhibitory pathway developed. So when we think about reward sensitivity, certain individuals have a tendency towards a greater reward seeking aspect, whilst others may have slightly less. And this is why individuals with anhedonia or the hedonic drive also lie on a spectrum.